If you'd like to know more about revascularization as a procedure to handle open apices, then this video is for you. If you're new to the channel, my name is Siju Jacob. I've been a private practitioner for the past 25 years in Bangalore and Dubai. I've been using a surgical microscope in my private practice for more than 20 years, and I've been training dentists how to incorporate the surgical microscope in everyday clinical practice for more than a decade. If you've been here before and you found some value in the videos that I post every week, then don't forget to click on that subscribe button so that you get notified every time I upload a new video, which is usually every Sunday. You can also subscribe to my weekly newsletter. I've put the link in the description below so that you get even more useful information delivered right into your inbox every week. A few weeks ago, I talked about apexification as a procedure to handle teeth with open apices. If you haven't watched it yet, you can find it here on my channel to have a look. And one of the questions that I got asked a lot was, how about revascularization? So this week, I'm going to talk about revascularization as a treatment option to treat non-vital teeth with open apices. So when we look at the chart here, which tells you all the treatment options that are available when you treat teeth with open apices, you can see that the first thing you have to do is you have to divide it into vital and non-vital teeth. So if you have some amount of vitality left, then our goal is to do apexogenesis, which means we preserve whatever vitality is left and you allow the root formation to continue with the help of whatever pulp is still left, because the tooth is still vital partially. So the two procedures that you do when you aim for apexogenesis are pulp capping or partial pulpectomy. Whereas for non-vital teeth, you have these four options, and these are the two options which I covered in a previous video. Like I said, you can check it out here on my channel. So this week, we're going to talk about primarily revascularization, but we're also going to talk about apexogenesis. Just a quick differentiation before we get into it. Remember that apexogenesis is our attempt to preserve whatever vitality is already there. So the tooth is partially or completely vital to start with. So our goal in apexogenesis is to preserve that vitality. Okay, so that's why we do either pulp capping or partial pulpectomy and allow whatever vitality is still there to continue. Whereas with revascularization, you are dealing with teeth which are already non-vital. So there is no vitality left. There is no pulp left. Our goal is to regenerate the pulp and then hope that that pulp will continue to function like a normal pulp. So this is a key differentiation. So before we get into revascularization, let's just briefly look at what we mean by apexogenesis and how can we achieve apexogenesis either by pulp capping or pulpectomy. Pulp capping is a very common clinical procedure. What are the indications of pulp capping? This is courtesy a student of mine, Dr. Joe Thomas. Pulp capping, we look at cases where the caries is deep, the tooth is asymptomatic, and there's pain that disappears when stimulus is removed, which means the tooth are in what we call reversible pulpitis, not irreversible pulpitis. So this is a typical case of pulp capping where you find a tooth which doesn't have many symptoms other than the random sensitivity which disappears when stimulus is removed. So the clinician isolates the tooth and then starts cleaning it up. This is courtesy Dr. Joe Thomas. And then once you clean up the caries, you find a pulpal exposure. So you cover the pulpal exposure with biodentine or any bioceramic or MTA and then restore the tooth with composites. So this is a classic direct pulp capping which virtually every clinician employs in everyday clinical practice. So what if you have a case like this where there's deep caries, the tooth is symptomatic, there is strong pain that lingers when stimulus is removed, which means the patient has irreversible pulpitis, then of course you can't just put a layer of MTA over that. You have to remove a part of the pulp which is inflamed. So our goal when we perform partial pulpectomy for apexogenesis is to remove the coronal part of the pulp and then allow whatever pulp is there in the radicular portion to remain vital so that root formation can continue in the usual manner. So this is the goal of partial pulpectomy, allowing apexogenesis, which is a natural formation of the root, to continue. So let's take a look at a case. So this is a case where you have a large carious lesion and then we remove the caries and you can see inflamed pulp. So we remove the coronal part of the pulp. We perform a partial pulpectomy. Just a quick note about microscopic documentation. The pictures that you see here are all documented through the surgical microscope, and this is not very difficult to do. Virtually any clinician can buy a microscope, bring it into your practice, and take pictures like this. So clinical documentation is one among the several advantages that you get when you buy a surgical microscope and incorporate a surgical microscope in your own practice. To know how you can do that in your own general practice, do check out the online course, Microscopic Dentistry Simplified. I've put the link here in the description below. Now let's get back to it. That's step one. You can see here, we've removed the coronal part, and you have the radicular part, which is still vital. So that's the distal canal. These are the mesial canals. We leave the pulp as it is, and we put a layer of MTA over that, and we place some cotton pellet in this case and covered it with glass ionomer cement. So that's the post-op, how it looked. You can see the open apices here. So we removed the coronal pulp here, put MTA here, and then put a cotton pellet and covered it with glass ionomer. I asked the patient to come back after a week just to check that the MTA is hardened so that we can put a permanent restoration. But however, this patient disappeared and then turned up after 3 years because the coronal restoration had gone and he was having some pain. So when this patient came after 3 years, the good news is the root formation is almost complete here. But the bad news is he had some discomfort. So what we did was, you can see here, that's the fractured glass ionomer, and the entire tooth is black underneath. So we remove the glass ionomer, you can see the cotton pellet still there for 3 years. When you remove the cotton pellet, the entire tooth has become pitch black. That's because of the MTA, which has been left there for such a long time. But when we clean it up, you can see the reparative dentin that's formed in the mesial canal here, with some exposure over here, and then the distal canal here as well. And if you look at a close-up of the mesial canals here, you can see quite a lot of reparative dentin formed, but one part is kind of breached there, and this is the part that's causing the pain to the patient. So you can see it's quite inflamed here. But when you look at the distal part, it's quite clear and uniform, and there's a proper seal here of a reparative dentin that's formed there. So what we did in this case was we left the distal canal as it is because it's a proper uniform barrier formed there, and we cleaned out the mesial canals and obturated the mesial canals. The distals were left as it is, and then we built up this whole portion with composite resin, and then we asked the patient to wait for some more time and then decide what to do in terms of maybe a cuspal coverage or an onlay or something like that. The good news of doing something like this is you already gained 3 years for this young patient, and who knows, we might get even more a few years down the road. So when it comes to young patients, the goal is to delay the inevitable, which is extraction of the tooth. So the more you can prolong this, the better it is. So that's the whole goal of these sort of procedures, trying to preserve the vitality of the tooth. So that's how we started. If you look at the tooth here, and this is how the patient is 3 years later. So the apex is closed, and that's the advantage you get when you attempt apexogenesis. Now let's look at revascularization. As I mentioned before, when we talk about revascularization, we are no longer talking about vital teeth. The tooth is already non-vital. And as I mentioned, I've already discussed these techniques, apexification and bioceramic barrier. You can find it on my channel. I've already done a video on this. Have a look below in the profile and you'll find it. It was just a few weeks ago. But let's say as an alternative to traditional apexification or bioceramic barriers, you can do what we call revascularization. In revascularization, we are doing something that attempts to bring back the vascularity or make a non-vital tooth vital again. So that's the key difference. Okay, so what is the theory behind it? So this is a typical case where you can attempt revascularization. You have a central incisor here, which has gone non-vital. So there is no pulp here at all. It's completely non-vital, and there's a lesion here. Similarly, here as well, you can see there's a canal here, which has gone non-vital, and then there's a lesion here. So there is no vital pulp in either of these two teeth. So what exactly are we hoping to achieve in a case like this? The goal is that you clean out this non-vital part, or you kind of disinfect this coronal part, and in the perioapical area, you have stem cells, which you can induce into this canal, and the goal is that these stem cells will differentiate and help in forming new pulp or revascularize the whole tooth, which will perform all the functions that a pulp typically functions. So that's the goal. So these are the steps in revascularization. So you kind of clean up this area, the non-vital part here, and then you induce bleeding from the perioapical area into the canal. So there is bleeding into the canal, and this clot will act like a scaffold, which will be invaded by stem cells from the perioapical area, which will differentiate into pulp. So the goal is to regenerate the pulp, and once you have a regenerated pulp, then the tooth can form root or the root formation can form not just apically, but also laterally. That is the goal of revascularization. Then, of course, you want to protect the coronal part with a proper coronal seal, which usually involves MTA or some other bioceramic material, and followed by a coronal restoration here. So that is a theoretical part of revascularization. Let me show you how this looks clinically. This is courtesy Dr. Samir Jain, who's a colleague. So you have a tooth here, which is non-vital. There's a lesion here. So the goal is to first clean up the canal and then disinfect it or put some sort of an antibacterial paste here. Some clinicians prefer what we call triple antibiotic paste, which is 1:1:1 ciprofloxacin, metronidazole, and minocycline. Some clinicians prefer calcium hydroxide. You can use either of these two. You put that in the canal so that this canal becomes a sort of disinfected, or at least bring down the bacterial content. And then in the second session, you induce bleeding from the canal. So you allow the blood to flow into the canal and then leave that blood inside. You can even put a collagen matrix there to condense MTA or bioceramic again, but it's not absolutely necessary. But once you've done that, you put MTA over that. So this is MTA, and then you cover that MTA with a restorative material. So this is how it looks. So you have MTA here, there's a restorative material on top, and that's the blood clot there, into which you're hoping that stem cells will invade into this area and then regenerate the pulp. So that's the whole goal. So in an ideal scenario, this lesion will heal, the pulp will form, and this tooth will start testing vital again. That is the goal of revascularization, and it does work to some extent. In fact, the American Association of Endodontists is spreading a lot of awareness, and you will find an entire link dedicated to regenerative endodontics. You can look it up in the American Association of Endodontists website here. You can see here there's an entire page with a lot of clinical resources. So if you're interested, have a look at the AAE website. You can find lots more information about revascularization. These are some cases shared by Dr. Rajiv Patel, who's an endodontist based in the US. He's a good friend of mine. So you can see in Rajiv's case, again, non-vital tooth with a sinus tract here. So what Rajiv's done in this case is revascularization. So it's gone in there and then cleaned out, disinfected it, and then put a layer of MTA with composite restoration on top. This is immediate post-op here. And then this is immediate post-op. This is a 1-year recall, and this is a 2.5-year recall. So you can see here how the roots closed naturally, and also some amount of thickening laterally as well. So this is a good result, and this is Rajiv's case. However, you have to be aware that revascularization doesn't work all the time. It can fail. So in terms of predictability, it's not as predictable as apexification or bioceramic barrier. So these are the key differences. Revascularization is time consuming. You have to induce bleeding, put a proper coronal seal, and then monitor and see whether it works or not. Whereas with MTA or bioceramic barrier, you can do it immediately. Apexification as well, it is time consuming because you have to place calcium hydroxide and wait for typically a year or more. The second difference is that there is huge variability in outcome. And this to me is the major difference, because some cases of revascularization work, whereas some don't work. Whereas when it comes to apexification and bioceramic barrier, it always works the majority of time. So predictability wise, revascularization is not as predictable as the other two. The third big advantage is that revascularization improves apical closure and cervical thickening. So this is one of the good things that happens when revascularization works, provided it works. If it doesn't, of course, nothing happens. Whereas when it comes to MTA or bioceramic barrier or apexification, the barrier is only apical. There is no cervical or lateral thickening. So that's the big advantage when it comes to revascularization. And that's why there's a lot of attention given to revascularization. Now, the person I would listen to when it comes to evaluating these techniques is Dr. Margari, who's an endodontist based in Purmerend in Netherlands. Marga is someone whom I consider a mentor, and she's someone who's treated a lot of open apice cases, a large number of open apice cases, and I would listen to someone like Marga. And Marga's published a paper along with Rich Swartz evaluating the long-term success of immature teeth with open apices, non-vital. And their conclusion is that non-vital immature teeth treated with an MTA apical barrier and adhesive restoration healed and remained in function for up to 15 years with no fractures. It can be concluded that this treatment approach is viable and predictable for long-term tooth survival. And Marga is of the opinion that revascularization works, and she does have a lot of cases where it worked, but she also shows you a lot of cases where it didn't work. So cases like this, for example, there is trauma in a 9-year-old boy. You can see here bleeding induced, MTA placed, but 1 year later you can see nothing's happened. You can see the adjacent tooth, one is closed, whereas the tooth in which revascularization is attempted, it still has an open apex. So this is one example of a tooth which failed. So Marga went back in there and found empty space here, and then disinfected the tooth, and then did traditional closure with MTA. You can see MTA barrier there. And then she did a post and core there. So that's the post-op. So this is a case where revascularization failed, and then Dr. Marga tried the other option of apical barrier using MTA. Here's another case of Marga's which didn't work out. A 10-year-old girl, you can see open apex, revascularization attempted, and then 2 years later, the apex is still open. So in this case, again, Marga went back in there. She found an empty space there, disinfected the tooth, put MTA at the apex here, and then put a fiberglass post. So that's the post-op. Here's another case where there's an open apex. Marga tried revascularization, and after 1 year, you can see it hasn't worked. The apex is still open. So re-entry followed by MTA barrier here, followed by a fiberglass post. So again, there's a 1.5 year recall. You can see these clinical techniques work. So in summary, can you do revascularization? Yes, you can, but don't expect miracles every time you do revascularization. It has its role, especially in teeth which are completely underdeveloped, where a large part of the tooth is still underdeveloped. Then yes, you can try revascularization, but at least put a rider to patients that, look, we're trying something experimental. If it works, great. But if it doesn't, then we probably have to do other procedures like, for example, apexification or a biceramic barrier or surgery in some cases. So just put that rider and then experiment with revascularization. So that's my take on this. If you are someone who gets confused every time you get an open apex case which needs endodontic intervention, I've put together a small document which tells you exactly what steps to follow so that you can make a clinical decision as to what protocol to follow whenever you get an open apex case. I put the link in the description below. Do have a look, and I'll send it to you right across. If you enjoyed that content, then maybe you would enjoy my weekly newsletter, which is a short email that I send out every Wednesday. It's usually filled with some useful dental and non-dental information. I've put the link in the description below. Do have a look and subscribe to my weekly newsletter called Wisdom Wednesdays. Don't forget to click on that subscribe button so that you get notified every time I upload a new video, which is usually every Sunday. And if you enjoy content like this, then maybe you should check out some of my other videos on this channel coming up over here. I'll see you next week with another video. Till then, take care. Thanks for watching.